Well, thank you so much. Thank you for having me here for this webinar. And so today I wanted to talk about lymphoma, and I thought I would start and keep it at the upfront management of lymphoma, and starting with two of the most common forms of non-Hodgkin lymphoma, diffuse large B-cell lymphoma and follicular lymphoma. My name is Ryan Lynch. I'm a faculty member at University of Washington. I work at the Seattle Cancer Care Alliance on the South Lake Union campus. So the goals of my talk are, as I mentioned, to talk about the two most common subtypes of non-Hodgkin lymphoma, diffuse large B-cell lymphoma, and in this I will integrate some aspects of prognostic scores to create an evidence-based treatment approach. And then for follicular lymphoma, there's a little bit more nuance, deciding which patients require systemic therapy, which patients require local therapy, and which patients require any therapy at all. So this is a pie chart looking at non-Hodgkin lymphoma incidence by subtype. And the largest slice here is diffuse large B-cell lymphoma, about 31% of non-Hodgkin lymphomas. Coming in second place is follicular lymphoma. And however, that only makes up a little over half of new diagnoses of non-Hodgkin lymphoma. On the other half of the pie chart are much smaller slices, including composite lymphomas, which refer to lymphomas that have multiple histologies, and then other ones that providers may have heard of, even non-oncologic providers: mantle cell lymphoma, CLL, SLL, Maltz lymphoma, and peripheral T-cell lymphoma. In terms of non-Hodgkin lymphoma incidence, there is an age-related increase over time in the incidence of non-Hodgkin lymphoma. Younger patients, it's not that it's uncommon in younger patients, it's just that it's much more common among older patients. And this appears to peak well over age 75 and 80, which does have implications in terms of management of these patients and the ability to receive intensive therapies. So I want to have you take a look at the y-axis on this, on the non-Hodgkin lymphoma slide, looking at 20, 40, 60, 80. When I show you the Hodgkin lymphoma incidence by age, where the numbers are much smaller. And the classic teaching in medical school for Hodgkin lymphoma is there's a bimodal distribution with a peak in the 20s as well as a peak in older patients. And so this is true, and many providers and even patients will say, oh, this is Hodgkin lymphoma. There's a young patient, it must be Hodgkin lymphoma. Even among patients in their 20s, there's only 4 to 5 cases per 100,000 people per year. And you go back to non-Hodgkin lymphoma, and it's not that much less than that. And especially as you get into your 30s, non-Hodgkin lymphoma is actually more common than Hodgkin lymphoma. It's just that relatively there is a bimodal distribution. And these are the raw numbers looking at lymphoma incidence per year. Non-Hodgkin lymphoma is almost 10 times more than Hodgkin lymphoma. It's about 8,500 new Hodgkin lymphoma cases and about 72,000 new non-Hodgkin lymphoma cases per year. I haven't looked at the table recently, but I think non-Hodgkin lymphoma, depending on gender, is about the 7th or 8th most common malignancy diagnosed in the US per year. And so one way that I like to divide non-Hodgkin lymphomas, and when I discuss this with patients, is that the first breakpoint I use is dividing it by behavior. So there are aggressive non-Hodgkin lymphomas, and these typically look very high grade on pathology or have very fast growing behavior. And this makes up about 60% of non-Hodgkin lymphoma cases in the US. And then there are indolent non-Hodgkin lymphomas. These can also be referred to as low grade, slow growing, not aggressive. So these typically will have smaller cells on pathology, much more indolent behavior over months or years. And this makes up about 40% of non-Hodgkin lymphoma cases in the US. And so I like to put this on a spectrum. So even though I talk about these two categories, one side by side, it really makes up more of a spectrum where on one side you have these aggressive lymphomas, and when I see a new aggressive lymphoma, these patients need prompt intensive therapy after diagnosis. So shortly after we get the diagnosis, usually within a week or two, I like to be able to have all the workup I need, staging, and start therapy. And for these aggressive lymphomas, the goal is generally cure, intensive therapy to try to make all the lymphoma go away and never come back. And the success varies based on the subtype, as well as certain risk factors of the patients. And unfortunately, in aggressive lymphomas, relapse disease is very challenging to treat. So despite the curative ability in many patients, for patients who fail upfront therapy, it can be very challenging to eventually get a cure. On the other side are indolent lymphomas, and these are much more nuanced. This is oftentimes in clinic a much longer conversation with patients because there's much more nuance and things aren't always so black and white in these patients, and there can be multiple different management strategies that can be reasonable in patients, including observation. In asymptomatic patients with indolent lymphomas, these patients can be observed. In contrast to the aggressive lymphomas, the goal in managing these patients is to reduce symptoms, delay progression, and prolong lifespan. But this is not thought to be curable, unfortunately, with modern therapies. But in contrast, most patients will have a life expectancy near their age-matched controls. With indolent lymphomas, most patients do respond to treatment despite the fact that we can't get rid of all of it all at once. And even relapsed patients with indolent lymphomas can still have very high rates of treatment success. So these are just a few examples of non-Hodgkin lymphoma subtypes by behavior. On the left column are low-grade or indolent lymphomas, and I put follicular lymphoma at the top, and then the rest is in alphabetical order. And then on the right side, I have some examples of high-grade or aggressive types of lymphoma, with diffuse large B-cell lymphoma at the top. Notice I put mantle cell lymphoma on both sides. That could be a topic of an entire talk. There's many nuances with mantle cell lymphoma, but it can have behavior that's both indolent and aggressive. So, and just to switch to the diffuse large B-cell portion of the talk, this is the most common lymphoma subtype and certainly the most common aggressive non-Hodgkin lymphoma. And chemoimmunotherapy, or a combination of chemotherapy as well as antibody-based therapy, is curative in about 60% of unselected patients. And there's a combination that's been around for well over 15 years called R-CHOP. This is a combination of drugs including rituximab, a monoclonal antibody against CD20, which is highly expressed on mature B cells, 3 chemotherapy drugs, cyclophosphamide, doxorubicin, and vincristine, and then the P stands for prednisone, which is given over the first 5 days of each treatment. And so the development of rituximab really revolutionized the treatments of diffuse large B-cell lymphoma and really B-cell non-Hodgkin lymphomas in general. There were several trials that led to the approval of rituximab. This is just one of them, a GILA trial. And in patients who received rituximab, in addition to standard CHOP chemotherapy, had a significant improvement in overall survival and progression-free survival. As I mentioned, there were several other studies that also demonstrated this superiority. Unfortunately, since the publication of these studies, there hasn't been a single regimen that has been found to be superior in a phase 3 randomized trial in unselected patients with diffuse large B-cell lymphoma. However, this isn't for a lack of trying over this time frame. So there have been several strategies that have been employed to try to improve outcomes in an unselected patient population. Before the development of rituximab, it was found that giving dose-dense CHOP, so instead of giving it every 21 days to give it every 14 days, was associated with an improved 5-year overall survival. However, in the rituximab era, this was not found to be a case. There was no significant advantage of dose-dense therapy when you add rituximab to patients. When available, I try to draw your eyes to the number of patients that were enrolled in these studies. Many of these negative trials had many patients. This was over 1,000 patients in this trial. So what about a next generation anti-CD20 antibody? So rituximab was initially developed, but there have been new strategies to develop antibodies for therapeutic purposes that have slightly different mechanisms of action. One of these is called obinutuzumab. It's also known as Gazyva. So the only reason I mention that is because G is often used in many of these trials as the initial for obinutuzumab. And so this is designed to have more antibody-dependent cell killing as well as indirect cell death versus rituximab. Unfortunately, when these rituximab and obinutuzumab were compared up front in a randomized trial of over 1,400 patients, there was no difference in progression-free survival. So what about giving more intensive therapy with some of the same drugs? So this regimen was developed at NIH, Wyndham Wilson at the NIH, and the strategy behind this is to give the chemotherapy over an extended period of time, but also adjust the doses of chemotherapy based on the ability of the patients to tolerate it. So I'll draw your eyes to this column here, dose level 1. So all these patients will start at the doses indicated here. So etoposide is added to this over, which is not in R-CHOP, and it's given continuously over 4 days. So instead of giving a bolus over minutes, the dose is spread out over 4 days. And the idea behind this is to eliminate the peaks for these patients. This can potentially decrease cardiac toxicity, but also deliver a sustained amount of chemotherapy to the lymphoma cells. And the principle behind this is that in these patients with very aggressive lymphomas, just a single big hit, they can recover from quicker, but when you give the chemotherapy over several days, it's harder for them to recover and increases killing. That's the principle behind this. And so after the patients receive this over the course of 5 days, they're monitored for their labs over the next 2.5 weeks. And as long as the blood counts, specifically the absolute neutrophil count, doesn't drop below 500, or the platelets don't drop below 25,000, we can actually increase the dose of 3 of the drugs by 20%. And so that's the etoposide, doxorubicin, and cyclophosphamide. And so some patients, particularly younger patients, can get a very intensive therapy by cycles 3, 4, 5, and 6. And patients who aren't able to get a more intensive therapy may stay at the lower numbers or even have their doses decreased. And so the goal is to maximize therapy intensity in patients who can tolerate it. So shortly after the approval of rituximab in this setting, there was a randomized phase 3 trial that was designed to compare newly diagnosed diffuse large B-cell lymphoma patients to receive dose-adjusted EPOCH-R, so this intensive infusional regimen, versus R-CHOP for 6 cycles. Pretty straightforward design and stratification, primary endpoint being event-free survival, and they estimated they would need 465 patients. But unfortunately, when these results were presented a little over a year ago at the American Society of Hematology meeting, there was no major difference between these two patient populations. The overall response rates were virtually the same, CR rates were virtually the same, and when you look at the event-free survival Kaplan-Meier curves and overall survival curves, there wasn't a significant difference between these two. And so there are several theories as to why this ended up being the case. One may have been that the control arm did much better than expected, and there could be some selection bias. Some of the sickest patients or some of the patients who have the highest risk disease may not have been able to get on this clinical trial. So this may have been selected for a more favorable population that would probably do well no matter what regimen you gave them. We don't have any of the subset analyses yet, and there has not been a formal publication of this that may be more informative for this. But in an unselected population, which is what this was, there is no difference. In addition, as one might expect, there was also increased toxicity with the more intensive regimen. Almost by design, there were higher rates of neutropenia, thrombocytopenia, but there was also higher rates of febrile neutropenia in these patients as well. In addition, there was also higher rates of neuropathy, both motor and sensory neuropathy, in the patients who received EPOCH, the more intensive regimen. So other strategies have been attempted as well. One such strategy was giving an auto transplant to patients in their first remission, particularly in high-risk patients, as this improves survival. So the one strategy with autotransplant is that the patient's stem cells are harvested ahead of time and processed and frozen, and then the patients then receive a high dose of chemotherapy, a dose that would be essentially lethal or cause bone marrow failure if we didn't promptly rescue them with their stored stem cells. And so the idea behind this is to give a higher dose of chemotherapy than would be possible in a conventional strategy. And so while there was an improved progression-free survival in patients who received upfront transplantation, there was no overall survival benefit, which may suggest that the upfront transplantation isn't curing any additional patients. It's essentially giving the transplant earlier in the process. The patients who don't get the upfront transplant might still benefit from a transplant later on. So for now, R-CHOP times 6 remains the standard for untreated diffuse large B-cell lymphoma. However, diffuse large B-cell lymphoma is a very heterogeneous disease, and we've learned a lot about the biology and different subtypes of this since that initial randomized clinical trial looking at the intensive EPOCH chemotherapy was designed in 2005. And so a subset of patients, despite the lack of phase 3 randomized evidence, may benefit from an altered approach than R-CHOP times 6. And so the way I like to illustrate that is to start with a common prognostic index in diffuse large B-cell lymphoma known as the International Prognostic Index. And so this is been validated even in the rituximab era and looks at 5 factors. This includes age, performance status, LDH, extranodal sites, as well as the patient's stage. And each additional factor can lead to lead to worse outcomes in patients, as illustrated by the Kaplan-Meier curves on the right. Patients with 0 or 1 risk factors do far better than those who have 4 or 5 risk factors. So what I'd like to do is take this initial strategy, and when I look at new patients with diffuse large B-cell lymphoma, and just add one more P to it. So you really actually do get the word apples in this instead of kind of the word apples. And to show how I approached patients with a new diagnosis of diffuse large B-cell lymphoma. And I find it a little bit easier to start out of order. So I'll start by examining how we can use the patient's stage to approach a new diagnosis. So can early stage diffuse large B-cell lymphoma patients receive an abbreviated therapy with the use of radiotherapy and consolidation? So to start, just to briefly go over lymphoma staging, it's very different than other solid tumors, but also a little bit, it's also a little more simple, and it's not as specific in terms of depth of invasion, size, etc. It mostly refers to the location of the sites of disease. So patients with stage 1 disease may have a single lymph node or a single site involved. And when I say single lymph node, that could be multiple lymph nodes within the same group. So patients can have multiple cervical lymph nodes involved, but only on one side of the neck, for example. Patients who are stage 2 will have 2 or more involved lymph node regions. So this can be both sides of the neck, neck and axilla, as long as they're all on the same side of the diaphragm. And so the same would go for patients with infradiaphragmatic disease, multiple lymph node sites below the diaphragm but none above. Patients who have lymph node sites on both sides of the diaphragm would be stage 3. And then patients who have stage 4 disease have evidence of disseminated involvement, so bone marrow involvement, extranodal sites like the liver, etc. And so the other things that we add to this are A and B, so it's the presence of B symptoms. Those include fevers, chills, unexplained weight loss of more than 10%, or night sweats. And so we just add an A for the absence of B symptoms and B for the presence of B symptoms. And so when we say early stage versus advanced stage, early stage refers to stage 1 and 2, and advanced stage refers to stage 3 or 4. So in the pre-rituximab era, abbreviated chemo and radiation was superior to chemotherapy alone. So early stage patients received only 3 cycles of CHOP chemotherapy and radiation, did actually better than those who received a full 8 cycles of CHOP chemotherapy. In the rituximab era, there's less data, that's less clean data than before. There is some retrospective data as well, some phase 2 data that do show that patients who have abbreviated R-CHOP with 3 or 4 cycles in radiotherapy do have excellent outcomes. There was a trial in Germany that has not been formally presented at any conference or been published in any journal. It's known as the Unfolder trial. And they looked at patients who had bulky disease, early stage disease, so more than 7.5 centimeters. And it appeared that getting radiotherapy and 6 cycles of R-CHOP was better to 6 cycles of R-CHOP alone. So it did appear there was a benefit to radiotherapy, even if you receive a full chemotherapy course in these bulky patients. Although we don't have the final data from this, we know that the radiotherapy-free arm was closed early in this trial, and so we can infer some information from that. And then a French group looked at radiotherapy in non-bulky disease, and it appears if you get a full 6 cycles of R-CHOP chemotherapy, there wasn't a benefit to radiotherapy. So the next factors to look at are both age and performance status. So how do older age as well as worsening performance or functional status affect how we manage these patients? So in elderly patients, which is typically defined in lymphoma as greater than age 80, there's very limited data on how to treat these patients. In a retrospective review of Medicare SEER data, it does appear that giving R-CHOP chemotherapy to these patients is associated with improved survival, even on multivariate analysis. Of course, there's limitations to these retrospective reviews. Individual patients may have different factors that make this kind of intensive therapy not feasible. There's a publication in 2011 that looked at abbreviated doses of R-CHOP. It's also referred to as R-mini-CHOP, which gives 50% dosing of most of the drugs. And there's pretty good for this age group overall survival at 2 years, about 59% with this regimen. I haven't seen long-term follow-up of this at all, but it does appear that it's safe and well tolerated. But even in this population, there's a treatment-related mortality of 8%. And so this really helps illustrate some of the challenges in treating aggressive lymphoma in older patients. Even giving abbreviated doses is associated with a high rate of treatment-related death. And most patients, a lot of our patients are over age 75 in this population, so many of these patients would be eligible for these kind of therapies. And so what if a patient has very poor performance status or heart failure? So doxorubicin, which is in a class of drugs known as anthracyclines, are associated with heart failure in a small subset of patients, and it's thought to be dose dependent, and much of this was learned from the breast cancer population, where if we keep the dose under 400 to 450 milligrams per meter squared cumulative over the course of the patient's lifetime, the risk of heart failure is much less, though it's not zero. And the heart failure can often present 5-10 years or more after the initial diagnosis or administration of the drug. So if patients already have heart failure at presentation, we'd like to avoid doxorubicin in these patients, and so substituting etoposide in this setting is reasonable for these patients. We also know that patients with poor performance status may not be able to tolerate the more intensive therapy, so we can adjust the doses as necessary, substituting etoposide, or even giving a relatively low intensive therapy with just cyclophosphamide, vincristine, rituximab, and prednisone, which is palliative in most patients, but tends not to cause the same cytopenias or complications as the other more intensive regimens. And so the next step is to really focus on the pathology of these patients. And it's very easy to, when one sees a pathology report, to just look at the one line at the top and not read the meat of the report below. But it's important to look at certain factors. Different pathologists highlight them better than others. And so it's just important to look out for a few factors when making a treatment decision. And one reason for this is that in 2016, the World Health Organization, who about every 8 years or so comes out with an update on the diagnosis and classification of lymphoid neoplasms, really rearranged how we look at aggressive B-cell non-Hodgkin lymphomas. And the graphic on the right was pulled from the blood publication by Swerdlow and colleagues in 2016, and showed that many patients who had diffuse large B-cell lymphoma, or would have been classified as diffuse large B-cell lymphoma previously, now are in a category, now can be in a different category that's much more aggressive. It eliminated a category called B-cell lymphoma with intermediate features of diffuse large B-cell lymphoma and Burkitt lymphoma. That category was eliminated, and those patients were put into two categories: a high-grade B-cell lymphoma, not otherwise specified, or a category that's more commonly referred to as double-hit lymphoma or triple-hit lymphomas. Those double-hit lymphomas were previously referred to as diffuse large B-cell lymphoma, now have their own category. And so this does have treatment implications as well, because patients who have double-hit lymphoma have inferior outcomes with standard R-CHOP chemotherapy. So the Kaplan-Meier curve on the right, and the blue line refers to other patients with diffuse large B-cell lymphoma, patients who didn't have these abnormalities, and they have the expected survival over 5+ years and cure rates. And then the gray curve refers to patients who have chromosomal rearrangements affecting the MYC gene as well as the BCL2 gene. And these patients have very inferior outcomes, and long-term survival is probably 20% or less in this population. And another interesting category in here is the yellow column. And so this refers to patients who have increased expression, so increased protein expression of MYC and BCL2 without any clear chromosomal abnormality. And their outcomes are generally intermediate to those with double-hit lymphoma as well as standard, not otherwise specified diffuse large B-cell lymphoma. So that begs the question, since these patients have inferior outcomes, should we use a more intense regimen in these patients? So this is a review of patients who received intensive induction regimens in double-hit lymphoma, so a retrospective review. And it appears that patients who received some intensive regimen instead of R-CHOP had better long-term outcomes. Certainly not as good as the low-risk patients who have a 60 to 80% long-term survival, but certainly better than the curve below, where patients have a less than 20% chance of cure with their upfront regimen. And so when they stratified based on the type of induction regimen, I'll highlight there's a familiar regimen here called dose-adjusted EPOCH-R in the blue line. Those patients seem to do well. MD Anderson does like to use R-hyper-CVAD, that's the red line. And so those patients also seem to do well. This wasn't powered to look between these two regimens. It was mostly stratifying to see if there were really any, just to show patients, or just show providers that multiple different strategies were used. And then this R-CODOX-M is a Burkitt lymphoma-like regimen. And so there isn't a clear standard that one should use in this situation, but it's clear that that providers should be using some intensive strategy in patients with double-hit lymphoma if they're able to tolerate it. There was a prospective study looking at patients who have a chromosomal rearrangement in the MYC gene using the regimen dose-adjusted EPOCH-R. And this was presented at American Society of Hematology meeting in 2014. It seems about 45% of these patients were true double-hit lymphomas, and they demonstrated about an 80% progression-free survival at 12 to 18 months with a clear plateau after about 18 months. Short follow-up, median follow-up of 14 months, so probably much past 18 or 24 months, you can see a lot of these patients are censored. If you look back at the MD Anderson data, usually around 2 years that there is the start of a plateau. There's very few relapses after about 2 years. Another pathology subtype that is distinct and oftentimes not explicitly highlighted on a pathology report is primary mediastinal B-cell lymphoma. This can mimic Hodgkin lymphoma in many ways. It can mimic Hodgkin lymphoma based on its morphology. So just looking at the slide without any staining at low power, the Hodgkin lymphoma and primary mediastinal lymphoma can look very similar. It affects younger patients, so the median age of diagnosis is 35, and it does have a predominance in females, about 2 to 1 female predominance. And so the common presentation is a dominant mediastinal mass with direct extranodal extension or involvement in neighboring lymph nodes. There can be advanced stage or bone marrow involvement in patients, but it's much less common. And the pathology can even have some markers that are similar to Hodgkin lymphoma as well. And so there is some controversy in how to manage patients with limited stage disease. There have been several. There's actually even one recent review or editorial that discussed the data that supporting or not supporting a more intensive therapy. One advantage of using dose-adjusted EPOCH-R is that it's been shown to have good outcomes in the absence of radiotherapy. This can be very advantageous in particularly in younger patients, particularly younger female patients, to avoid some of the later effects of radiotherapy. This is a disease primarily of younger people, so this can have a significant advantage in decreasing breast cancer risk, risks of heart disease later on in life. Patients who support radiotherapy or less intensive chemo and radiotherapy like to highlight that radiation has gotten safer in recent years, and the ability to avoid neighboring sites has gotten better. But unfortunately, it takes several decades to know the extent of the long-term effects from radiation. So this will remain to be controversial. I prefer to use the dose-adjusted EPOCH-R in these patients, and we can avoid radiotherapy, but again, this is a subject of debate. In advanced stage patients, using radiotherapy isn't feasible, so typically the more intensive regimen dose-adjusted EPOCH-R is used in these patients. Unfortunately, one tends to get only one shot with these patients. Refractory relapse disease is very challenging to treat. There is some promising data using immunotherapy, whether it be antibody-based immunotherapy or CAR T-cell therapy in these patients, which could be the subject of another talk. But historically, this has been very challenging to treat for patients who fail upfront therapy. There was a prospective as well as retrospective publication in New England Journal of Medicine between the NCI and Stanford, showing that there's excellent outcomes in patients who receive dose-adjusted EPOCH-R upfront primary mediastinal lymphoma. Another aspect of pathology that's interesting to examine is something called cell of origin, and diffuse large B-cell lymphoma is a mature B-cell malignancy, but depending on which part of the maturation of the B-cell the lymphoma develops can have implications for the behavior as well as outcomes with chemotherapy. Patients who have a B-cell phenotype that's more similar to a germinal center B-cell tend to do better with treatment than those who have an activated B-cell subtype. So there is no randomized data, unfortunately, at this time to support escalated regimens in the activated B-cell subtype, but there are studies that are ongoing, including randomized studies in this specific population. So over the next several years, we may have some data to support this, but for now remains an area of controversy as well. And this just highlights some of the other induction regimens that are under study in the phase 3 setting. There are others that are in conception or just opening. It's a very tough space to do phase 3 trials, as illustrated by the number of negative trials that I've shown in earlier slides in this presentation. Other ways to add to R-CHOP, there's a drug called ibrutinib, which is an oral BTK inhibitor that's approved for other types of lymphoma, including CLL. Lenalidomide is an oral immunomodulatory agent that's also being combined in this ABC subtype in a phase 3 clinical trial. And brentuximab, there was a phase 3 trial with the antibody drug conjugate called brentuximab. Unfortunately, this trial closed early due to poor accrual. I haven't seen any results, even incomplete results from that phase 3 study, but it closed within the last 1 or 2 years. So in summary, of this pathology section, we know that patients who have rearrangements in MYC need a much more intensive therapy, and it's not clear which one should be used, but one should use a more intensive therapy. I prefer to use dose-adjusted EPOCH-R. It's easier to use for patients as well as even patients who are slightly older. For patients who have double expressor lymphoma or double protein lymphoma, it's very controversial. We know they don't do as well with R-CHOP, but there isn't prospective data, and the retrospective data is not as strong as with double hit. And so this can be a case-by-case basis to decide if someone should receive a more intensive therapy, even if there isn't randomized data to support it. Patients who have a high-grade B-cell lymphoma, which is a new category, should also receive a more intensive therapy. And then those who have the activated B-cell subtype of diffuse large B-cell lymphoma, for now, in the absence of a clinical trial, should receive standard R-CHOP, but there may be new data to this over the next several years. And the last aspect of this is looking at the risk of CNS relapse. And so to illustrate this, we look at elevated LDH as well as extranodal sites. So who needs CNS prophylaxis in diffuse large B-cell lymphoma? We know that the standard chemotherapy drugs do not penetrate the central nervous system, and highly aggressive B-cell non-Hodgkin lymphomas can have a risk of hiding in the CSF, and so patients may be cured outside of the CSF but relapse later on with CNS symptoms and unfortunately have disease either in the fluid or even masses in the parenchyma of the brain. Highly aggressive lymphomas seem to have a much higher risk of this, so this includes lymphoblastic lymphoma, Burkitt, intravascular. There's even some suggestion that a small subset of diffuse large B-cell lymphomas with CD5 expression may have increased risk. Patients with MYC rearrangements as well as double expressor lymphomas appear to have a higher risk as well. There's several reports that are looking at certain sites may have a higher risk, so those who have involvement of the testes, breast, orbit, or epidural space may have higher risk. Historically, having an elevated LDH at diagnosis in more than one extranodal site was a reason to do CNS prophylaxis. Bone marrow involvement is often an indication. And recently, there's a group that looked back at patients and used components of the IPI score to develop a risk score for patients who are at risk for CNS relapse. And in these patients, they used the components of the IPI score that I listed above. They added a sixth factor, which is involvement of the kidney or adrenal glands, and created a score. And so patients who have a score of 4 or higher have over 5% risk of CNS relapse. And generally, that's about the threshold that is often used for giving prophylaxis of the CNS in these patients. There may be some other factors that I listed on the previous pages that may tip a provider to give CNS prophylaxis as well. What to use for CNS prophylaxis, many of these high-risk regimens actually incorporate CNS prophylaxis into their regimen. And so this can be either through high doses of methotrexate. High-dose IV methotrexate can penetrate the cerebrospinal fluid. Patients can also receive intrathecal methotrexate or cytarabine. Those are both safe to give in that setting. Patients could also just receive intrathecal chemotherapy alone. Although that's typically just used for high-risk diffuse large B-cell lymphoma patients. Patients with these really high-grade or Burkitt-like lymphomas often need IV methotrexate as well due to the higher risk. So there's other considerations when we diagnose diffuse large B-cell lymphoma patients. We have to be very careful at diagnosis with bulky disease, making sure that patients are well hydrated or allopurinol. For patients who seem very high risk or very bulky, they can even be admitted and monitored for their first cycle. We always get baseline hepatitis as well as HIV testing. Management of HIV lymphomas can be very challenging. It's important to know this at baseline and can really be an entire topic on its own. And with hepatitis B, there is a risk of reactivation. So patients who have a core antibody positive, whether or not they're surface antigen positive, should receive prophylaxis with entecavir or a similar drug during the course of treatment. And of course, we need to get a baseline echocardiogram. So in summary, early stage lymphoma patients, it can be reasonable to abbreviate chemotherapy with radiation, but also can give the full course if necessary. And radiation, even with a full course of chemo, can improve outcomes. Patients over age 80 or poor performance status can have abbreviated chemo or substituted drugs. Patients with aggressive histologies should receive an intensified regimen. And CNS prophylaxis is easy to overlook, and so I always advise providers, don't forget to use this on patients with risk factors. And so for the last third of the talk, I'll talk about follicular lymphoma, which is very different in behavior than diffuse large B-cell lymphomas. It's the most common subtype of indolent B-cell non-Hodgkin lymphoma. This, in contrast to diffuse large B-cell lymphoma, that it has a more nodular growth pattern in the lymph node versus a diffuse pattern. The 85% of patients have a translocation in BCL2, which is a 14-18 translocation, although it's not necessary for the diagnosis. And for most patients, it's rarely curative, particularly in advanced stage patients. So at least in 2018, we don't think our therapies are curative. But we know that patients are living longer, and I like to think of it as managing patients like a chronic disease. For patients, for example, who have diabetes and receive insulin, the insulin's not curative, it's managing the disease. And one can modify risk factors to try to decrease the amount of therapy that's needed, just like in many chronic conditions. There was a review in the rituximab era that's demonstrated that in this era 4 here, from 1997 to 2003, patients diagnosed since the development of rituximab, the median overall survival hasn't been reached. And so we know that many of these patients do very well. From a pathology standpoint, there is a grading system, and over the course of the grading, it looks more and more like a diffuse pattern like diffuse large B-cell lymphoma. And even patients who have even grade 3 is divided into grade 3A and grade 3B. And grade 3B is often treated like diffuse large B-cell lymphoma. It looks very similar to it. And there is even some suggestion that grade 3B may be curable, particularly if that's the only histology that's present. But usually lower grade 3A and lower, we generally think they're treated more indolently and generally aren't curable. So what are the indications for treatment? So not every patient with follicular lymphoma needs to be treated right away. I can't tell you how many times in clinic we have patients rush in to be seen and are taken aback when I make the recommendation that we should observe their disease. It's very hard for some patients to understand and can be very challenging psychologically to handle, knowing that you have a cancer, but it doesn't have to be treated at that moment. The criteria that we typically use are criteria, we call them GELF criteria, and that's actually, GELF stands for a French lymphoma group, and I don't know the words off the top of my head, but generally this refers to the bulk of the tumor. So if patients have bulky disease, it would be an indication for treatment. If there's systemic symptoms, splenomegaly, vital organ compromise, so for example, if there's follicular lymphoma pressing on a ureter and causing hydronephrosis, that would be an indication for treatments, even if it doesn't meet any other criteria here. Pleural effusions or ascites, circulating lymphoma cells, as well as cytopenias are generally reasons to treat. If patients do have evidence of transformation to an aggressive lymphoma, like diffuse large B-cell lymphoma, always treat it like the most aggressive histology that's known. So that would be treating it like diffuse large B-cell lymphoma. There is however, some thought that early stage follicular lymphoma may be curative. There's about a 40% 10-year relapse-free survival when Stanford looked at their patients. The concurrent use of chemo or rituximab is mixed. It's unlikely to provide added benefit, but there's some mixed retrospective data. And so for patients with early stage disease who can be radiated, we typically only reserve systemic therapy for symptomatic patients who can't receive a definitive radiotherapy dose. Interestingly, this is just to demonstrate some of the benefits of observation. Even in early stage follicular lymphoma, patients seem to do well even without initial therapy. So the Stanford group looked back at 43 patients who were initially observed with early stage follicular lymphoma, and they had an excellent 10-year overall survival, and 56% of the patients didn't need any treatment over 10 years. But what about an advanced stage follicular lymphoma? Should this be treated even when it's not symptomatic? In the pre-rituximab era, there was a randomized study that looked at treating asymptomatic patients with advanced follicular lymphoma and randomizing them to observation or a drug called chlorambucil. And there did not appear to be a difference in the median survival between the two groups. And interestingly, at 10 years, 19% of the observation patients did not require any treatment at all. So we know that it's hard at diagnosis to see which patients may behave even more indolently, but this is one reason to support observation in these patients. There's a good subset of patients that may not require treatment at all at 10 years, or may have treatment delayed 5 or 7 years or longer. This is another study looking at asymptomatic advanced stage follicular lymphoma patients. So there were 3 arms in this group. One was watch and wait, so observation alone. Another was giving single agent rituximab, no chemo, just rituximab. And then the other group was giving rituximab, but then also continuing rituximab every 2 months for 2 years as a maintenance. The column to the right shows overall survival, so there was no difference in overall survival between these groups. And you look at the left, as one might expect, the time to the start of a new treatment, if you've never received treatment, is worse. But 46% of the patients who were observed initially didn't need treatment at 3 years. And there was also no improvement of quality of life in these patients. We do know that there's been an evolution in the management, even with chemotherapy, of symptomatic patients with advanced stage follicular lymphoma. Historically, patients were given some sort of Cytoxan-based regimen. This is a randomized study looking at 3 arms. One is R-CHOP, which is familiar from diffuse large B-cell lymphoma. Another is RCVP, which eliminates doxorubicin in these patients. And another one called rituximab, fludarabine, and mitoxantrone, which generally isn't given. It's thought to be much more toxic and not necessarily better than R-CHOP. But it does appear that R-CHOP is probably better at improving progression-free survival in these patients, though RCVP is also effective and significantly less toxic. There's also been looking at rituximab maintenance in these patients. So the strategy of this is to give some sort of upfront treatment regimen to patients and then give this low-intensity monoclonal antibody against CD20 every 2 or 3 months after completion to try to delay the progression of disease and delay the need for the next treatment. And so the frequency and duration of maintenance have varied based on the study design, but generally every 2 to 3 months, and I've seen up to 4 years in one study, but generally 2 to 3 years is what has been used in the studies. And so the main benefit to rituximab maintenance is improved progression-free survival, but there is not been good evidence supporting an overall survival benefit in patients who receive rituximab maintenance. There are a couple clinical trials that have tried to look at different chemotherapy regimens in symptomatic follicular lymphoma patients. There's a drug called bendamustine that was compared in a randomized study to R-CHOP in follicular lymphoma. And it does appear that there is a progression-free survival to the bendamustine-based regimens over R-CHOP. And there's significantly less toxicity with bendamustine-based therapies, lower risk of cytopenias, virtually no alopecia in those patients. And so it's much better tolerated, especially in older patients. And so in this study with median follow-up of 45 months, this is just to highlight that as well, much less neuropathy and hematologic toxicity as well. And so is obinutuzumab better than rituximab with combined with chemotherapy? So this is, I had mentioned this earlier in the talk, this is a next generation anti-CD20 antibody. And so this was a study, it was the plenary session at the American Society of Hematology meeting in 2016. The randomization in this trial was to the antibody that was used, so the older rituximab versus the newer obinutuzumab. The chemotherapy backbone was the investigator's choice, and then that was primarily done to allow for more sites to be involved. As I mentioned, it's controversial as to which regimen can be used based on providers. And so patients were randomized 1-to-1. Interestingly, all patients received maintenance after chemotherapy. So there was no patients that were just observed afterwards. But 1,200 patients were enrolled, and they had a median follow-up of 34 months. There did appear to be an improved progression-free survival with obinutuzumab-based chemotherapy. But interestingly, there was higher rates of infection with bendamustine in the maintenance phase of the trial. So even after the initial chemo, there appears to be longer immunosuppression, perhaps with bendamustine, and particularly with obinutuzumab-based chemotherapy. There's also some other critiques of the study. The way that the dosing of obinutuzumab was performed, the cumulative dosing of obinutuzumab was higher than the weight-based dosing given with rituximab. So there's some controversy in this as well. So while obinutuzumab has been FDA approved, it's certainly not been 100% adopted as the standard. We also know that there can be risk factors associated with better outcomes in patients with follicular lymphoma. We know that the end of treatment PET is associated with improved outcomes. So for those who receive their initial therapy for follicular lymphoma, if their PET scan is negative afterwards, they have much better overall and progression-free survival than those who still have PET active disease. There have been a couple retrospective reviews of follicular lymphoma patients that try to identify a subset of patients that we call the early treatment failures that seem to have worse outcomes over time. So for patients who relapse in follicular lymphoma within 2 years of their initial treatment, appear to have worse survival than those who remain disease-free after that 2-year period of time. So the curve on the right demonstrates about 90% survival at about 5 years for those who did not relapse, and is only about 50% in those who relapse within 2 years. So this early relapse appears to identify a high-risk subset of patients. This data was validated with the Mayo University of Iowa Lyon group, and they used an even more stringent factor called event-free survival at 12 months. So patients who remained event-free at 12 months actually have overall survival similar to their age-matched controls. Patients who do not remain event-free at 12 months are demonstrated on the curve to the right, have far worse outcomes both in the Mayo University of Iowa group as well as the Lyon validation cohort. We also know that histologic transformation of follicular lymphoma is an important consideration as well. So this is the transformation of a previously indolent follicular lymphoma into a clinically aggressive lymphoma, and this typically is diffuse large B-cell lymphoma. It occurs at a rate of about 2 to 3% per year, and for patients who previously received anthracycline-based chemotherapy and transform after that, the outcomes are particularly poor. Patients with transformed disease, single-agent rituximab or bendamustine-based therapy is considered to be inadequate, and the anthracycline-based therapy, R-CHOP, is considered standard. For those who previously received anthracycline-based chemo, they can use the RICE or RDHAP, which are platinum-based chemotherapy regimens as well. There's also the role of autotransplant is controversial. There isn't randomized evidence in the rituximab era, but there's a small subset from a previous study that validates a couple things that I've mentioned above. One is that we know that patients who have receive R-CHOP at transformation versus those who received it previously do better. We also know that the outcomes between those with de novo diffuse large B-cell lymphoma and histologic transformation, as long as they're treated with R-CHOP, tend to have similar outcomes. There's also the review of, there's a trial called the PRIMA trial, so looking at patients who have a histologic transformation after previous immunochemotherapy. They may benefit from autotransplant, but the numbers are pretty low, so only 17 or 23 patients in this retrospective review, but does demonstrate that autotransplant can be considered in these patients who have histologic transformation after upfront immunochemotherapy. So in conclusion, follicular lymphoma is rarely cured, but the goal of treatment is to relieve symptoms and maximize remission duration and treatment-free interval. And very importantly is to minimize toxicity given the long periods of time that these patients can live. One should always have a high index of suspicion for histologic transformation. So some factors that can be associated with it are bulky disease, rapid growth at a single site, or one area that has more FDG avidity than others. And so one should tailor the biopsy to the site that may have the highest likelihood of transformation. So the biggest and the brightest is on the PET scan is one way to think about it. One should adjust therapy based on prognosis, so this should include age or comorbidities. And one thing is early treatment does not necessarily prolong overall survival or prevent histologic transformation. So for a patient who comes in the clinic with asymptomatic advanced follicular lymphoma, I try to tell this to patients that we don't necessarily have to get in there and treat them aggressively and treat them fast. This is a long game for these patients. It's a marathon, not a sprint, and so we have to manage our treatments well and try to minimize toxicity and try to prolong survival as best as we can by using our tools only when they're necessary. So in early stage follicular lymphoma, radiotherapy is potentially curative, so I recommend it in patients who are staged as early stage patients if the radiotherapy is feasible. For advanced stage patients, we observe if there's no indication for treatment. And so for the grade 1 to 2 low tumor burden patients who have indications for treatment, one can give chemotherapy or rituximab alone. For patients with a higher tumor burden, we can give I like to give bendamustine-based chemotherapy, though it's not wrong to give R-CHOP or R-CVP. They're certainly in the guidelines, but I prefer bendamustine based on the efficacy as well as toxicity. For grade 3 patients, grade 3A and grade 3B, there's a distinction there. Grade 3B is generally treated like a diffuse large B-cell lymphoma with intensive chemotherapy. Grade 3A, I'm always cautious to make sure patients do respond to bendamustine and have a very low threshold to escalate in these patients. And of course, patients who have overt evidence of histologic transformation should receive R-CHOP or anthracycline-based therapy if they haven't already received it. I generally do not prefer rituximab maintenance due to the lack of overall survival benefit, and especially with bendamustine-based chemo, this concern of increased infections, even with the maintenance. But this is extremely controversial, and even certain experts in the field feel very strongly one way or the other. Unfortunately, many clinical trials are written with maintenance, and so, but with the data that we do have, I still think due to the lack of OS benefit, I prefer not to give it. And so that's all I have here, and I think there's some true-false questions for CME purposes, but I'm good to go. All right, thank you so much.